Good morning and welcome to the MARG group, the Multidisciplinary Advocates and Researchers Group. My name is Sharayla Haynes. I'm the Community Partners Project Manager here at Frontier CTSI, located at KU Medical Center. This is our last MARG meeting before we take our summer break, and so I'm very excited that we can close out with this esteemed speaker. Martie Ross has 30 years experience in the healthcare industry, first as a regulatory and transactional attorney, and now as a strategy and compliance consultant. With her deep understanding of healthcare policy and regulation, Martie helps providers succeed under alternate payment models with Medicare, Medicaid, and commercial payers. She engages with providers in developing clinically integrated networks and assists those networks in developing and executing work plans to improve quality and reduce costs. Martie has made hundreds of presentations to corporate leaders, state officials, professional associations on a broad range of industry topics. She leads PYA's healthcare thought leadership initiatives, having presented numerous webinars and authored dozens of articles and white papers. Martie's experience, creativity, and uncanny ability to find simple solutions to complex problems make her a trusted advisor to those navigating the ever-changing healthcare industry. Martie also serves as the director of PYA's Center for Rural Health Advancement. With decades of experience working with rural providers, Martie helps communities develop and implement transformational strategies to maintain critical healthcare services and improve population health. And today, I look forward to hearing Kansas Rural Health Transformation Plan. How is KUMC involved? Welcome, Martie, to the MARG stage. We appreciate you coming today.
Absolutely. Good morning, everyone. And first of all, we should have coordinated a little better because you just heard about my prior life. I joined the health system in February for the purpose of working on the Rural Health Transformation Plan. In my prior life as a consultant, I had worked with the health system for about a decade and a half on rural health issues. And it's that engagement with that project that that's been my personal path to working on the Rural Health Transformation Program. So let's start with a story to sort of get you all to the right place of the topic we're discussing this morning. And please interrupt me with questions. I'm sure the questions you ask are going to be much more valuable than any of the information I'll share here. But let's go back just under a year ago when Congress was debating the One Big Beautiful Bill. And as the clock struck midnight on July 1st, the bill was in trouble in the Senate. They needed a couple of more votes to secure passage. And that began negotiations around something called the Rural Health Transformation Program. There was concern by several senators from rural states, including our senators from Kansas, that the Medicaid provisions were going to negatively impact rural hospitals, resulting in closures. And they were looking for a solution to address that. And the compromise that was created was the Rural Health Transformation Program. It actually started out in the legislation at about $10 billion, then it became $25 billion. And again, somewhere in the middle of the night, it became $50 billion that was to be distributed to the states to support rural health transformation. The legislation included an incredibly tight timeline, requiring that the Center for Medicare and Medicaid Services actually distribute the funds to the state by the end of the calendar year. And so began, once that legislation was signed on July 4th, began a very rapid process by CMS to get these dollars out the door. There was a period between July 4th and September 14th where states were trying to figure out what this was going to look like, what the requirements were going to be. They were soliciting ideas from stakeholders in the rural health community. But truly, it was just sort of a feel it out. Where are we going to work? What's our team going to look like? Situation, because there was no direction coming out of CMS. On September 15, CMS actually released the notice of funding opportunity to the states. The only potential applicants were each of the 50 states. And it was the NOFO spelled out in great detail what the application needed to include, what the focus of each state's rural health transformation plan would be. It detailed funding based on certain objective factors. That was about half of the potential money available to the states. The other money was based on subjective factors, focusing in on that application that the state submitted, the story it told of how the state would be a mover and a shaker in the world of rural health transformation. The actual application was due November 5th. So if you do the math, that's 50 days to create an application. And each state was told to apply for $200 million. And then it would be, again, the quality, those objective factors and those subjective factors that would be determinative of the amount each state received. We knew as a baseline that if a state effectively submitted a completed application, whatever that may be, the state would receive 100 million. The second 100 million was sort of what we refer to now as the Hunger Games portion of the Rural Health Transformation Program, because it was competitive between the states of how much they would receive. But you came in saying $200 million, give us your best story, here are the guidelines. And the Governor Kelly had charged KDHE with responsibility for generating the application. And in early September, Governor Kelly made a phone call to Bob Mosier, who has served as the medical director for the UKHS Care Collaborative since its inception back in 2014. More on that in a minute. Bob Mosier had previously also served during the Brownback administration as the secretary of KDHE. He is by background a family practice doc who practiced out on the Colorado border for 20 years, had joined the faculty of KUMC, had served at a point in time as the dean of the KUMC Salina campus. So Governor Kelly called Dr. Mosier and said, so what do you think we should be doing in this space? And about 2 hours later, Dr. Mosier had committed the Care Collaborative to assisting KDHE with the development of the application. That led to a webinar in late September where the state solicited ideas from stakeholders saying, tell us what we need to put into this application, what you think will be transformative, give us a work plan, give us a budget, give us evaluative criteria. And in very short order, the state received well over 250 proposals from everything from small physician practices to large, national tech corporations, trying to figure out how they could intervene. We went through a stakeholder process in that 50-day period, trying to figure out what our plan would look like, and worked through a budget, had a lot of collaborative meetings, spent a lot of late nights. It was back like being a baby associate at a big law firm again. We're getting the application done. But the state of Kansas submitted its application a day early and not a dollar short. And therein begins our story. So as we work through this, I want to start with just some background on what is this thing we call the Care Collaborative over on the health system side. Just a second. This is always my problem, is finding the little button to move forward. Page down. There we go. The UKHS Care Collaborative Association, that's our official incorporated name, we just call ourselves the Care Collaborative, was launched by the health system back in 2014, funded by about a $12.5 million CMS Innovation Award. Very early in the days of the Innovation Center, this was their second round of just give us innovative ideas and we'll give you money. So the health system submitted its proposal to build a rural clinically integrated network. At that point in time, we had 13 partners, hospitals out in Northwest Kansas. We still refer to them as the original 13 colonies. But our plan was to help these 13 hospitals and their clinics adopt and maintain evidence-based practices focused on time-critical diagnoses. Initially, we started with heart and stroke, that later expanded to sepsis and trauma and the like. Also, we were to build an infrastructure to support these hospitals and their clinics, again, in developing programs for chronic care management services to deliver in their communities and to provide infrastructure support for these smaller hospitals to deliver that care. That's the beginning of the story, and there's a lot between here and where we are today, but the Care Collaborative now operates roughly as an ARC-listed patient safety organization. We have 93 organizations that participate across 76 Kansas counties. The organization itself has, in that period of time, secured and performed on multiple HRSA grants. We have also been the benefactor of several grants from the Patterson Family Foundation to expand the work that we've done. And we've worked in areas of substance use disorder, workforce, tele-enabled behavioral health delivery, kind of a very broad, wide-ranging curriculum of activities in which we've participated. The Care Collaborative has also sponsored an accountable care organization to provide a vehicle for rural providers to participate in alternative payment models, develop their competencies around value-based care. We first joined the Medicare Shared Savings Program back in 2017. We've evolved that participation, working with national partners, again, to support these rural providers as they look at value-based alternatives. That organization has evolved. We are now really focused on developing a clinically integrated network to do single signature contract negotiations with commercial payers. And if you are familiar with the payment landscape, the commercial payer landscape in Kansas, you can appreciate the challenge ahead as we work to find fair and reasonable rates through Blue Cross Blue Shield of Kansas in particular. But that is sort of our current aligned work. For those of you that need a visual like me, this is our current participant map across Kansas. I think we have participants in 70 of the 75 rural counties that have a hospital are a part of the Care Collaborative. There are other networks in Kansas. Yesterday, in fact, there was an announcement of the High Value Network that's based through the Cibolo organization, if you're familiar with that. Sturmont Vale has been funded to launch a network called Prairie Link, but certainly the Care Collaborative has at present the largest footprint across the state. So back to the Rural Health Transformation Program and how we came to the table to support KDHE as they develop their application. The application itself had to meet the program requirements that were specified by CMS. And you see there the 5 pillars of this organization. You'll see that reflected in the 5 initiatives that are part of the Kansas plan. We were told to build a plan that could be implemented over 5 years and that we could not make significant changes to the plan during those 5 years. So again, appreciate 50 days to basically start at scratch because no state had a rural health transformation plan sitting on the shelf ready to go. Kansas was very lucky that we've had a lot of great thinkers that have really been contemplating the challenges of rural providers. We've had a high level of engagement from our rural providers. So we had a number of shovel-ready projects that had been developed that really had suffered from a lack of funding. Where we ended up in Kansas as compared to other states, our grant that was announced in December of 2025, they were 3 days early. They had till December 31st. They actually made the awards on December 29th. Kansas was awarded $221.89 million, which was the 6th largest award of any state. And now we know that as we look forward to year 2 funding, CMS has made it abundantly clear that every state's success in year 1 is going to be determinative of their performance in year 2. We'll come back in just a second and talk about some of the challenges there. The program is run through the governor's office. She is the recipient of the award. She has delegated to KDHE responsibility for administration of the plan. So Secretary Stanek is the main project officer. Her chief of staff, Matt Laura, is the official project head. Then they have built infrastructure in KDHE to support this. KDADS is directly involved in all of the behavioral health programs, taking a lead there. An entity called the Kansas Rural Health Innovation Alliance, convened by the governor back in September, is a stakeholder group set to advise the state. In fact, that group met yesterday to review the progress the state has made in its implementation, but it's a very wide range of the private foundations, KHA, KMS, the Health Institute is part of it, Leading Age Kansas, Kansas Home Care, sort of the usual, shall we say, the usual suspects in Kansas rural health care. The state legislature has invited itself to the table. We had legislation that ran last year that gave a role to the legislature Luckily for Kansas, an oversight role and a reporting obligation by the state agencies to the legislature, as opposed to directly engaging in the project. I was at a conference last week in DC, talked to the head of the Florida program. They finally received permission from their legislature 3 weeks ago to begin spending their dollars. And that is not alone. And I believe Wyoming still hasn't made it that far. So other states have had very different engagement by legislature, very different approaches to the program. We have been very, again, lucky in Kansas that the legislature stepped back and took that more kind of oversight role. And then again, we are at the other piece of the table, the UKHS Care Collaborative. We are part of the executive team. And as you'll see, we have specific responsibilities for several programs. It is important to remember what RHTP is not. It was, even though it was part of the One Big Beautiful Bill, even though it was motivated by the intent to address the loss of Medicaid funding for rural hospitals, CMS will tell you over and over again, this is not intended to be a replacement for lost Medicaid reimbursement. If that was true, Kansas actually would not have done as well, because as a non-expansion state, we do not face to lose as much as expansion states do as these Medicaid reforms come online. We paid, as I like to say, we paid it forward by not having access to those dollars because we were a non-expansion state. And so we will not suffer as much now as other states will with the loss of funds, but that is not what this is intended for. It is not, you cannot use these funds for ongoing operations. A lot of rural hospitals would just like us to take the money and divide by the number of hospitals and send out checks because they are struggling financially, but very clear at CMS that is not permitted. It is not, you cannot use this as a continuation for unsustainable interventions. So the fact that you've lost grant money for your program this is not an opportunity to fill that with RHTP. And important, as CMS again also emphasizes, this is not a research project. This is not an opportunity to fund research. You are permitted under the Notice of Funding Opportunity to fund evaluation, but it is not required. And CMS has said that any monies that you use for evaluation, we're going to count that as part of your administrative overhead. And by legislation, a state cannot spend more than 10% of its award on administering the program. FYI, Kansas, as it stands today, is spending about 6% of its award on actual administration. It does not have a formal evaluation product within its plan. Whew, there's a busy slide for you. That's our plan. As I said, we are across 5 initiatives. Every plan was required to have initiatives. And you see that our initiatives range from primary and secondary prevention programs intended to reduce the incidence of chronic disease, to securing local access to care, focusing on workforce, moving towards value-based care, and of course, figuring out how to harness the data and technology to support high quality, broad access to care. Within our initiatives, the 5 initiatives, there are 24 separate programs, and within those programs, there are 55 separate work streams. Let that one sink in for a minute, what we're managing. And you see here the budget that's been assigned to each of these programs. And again, several of these programs have multiple projects under them. And then you can see the owner, which is the agency or the entity that takes the lead in the implementation of the program. So where you see CCA, that's us. We have 5 subrecipient agreements with the state of Kansas, 1 for each of the 5 initiatives. Our total amount for which we are responsible is just under 100 million. So we have about 40% of the grant for which CCA is responsible for administration, not necessarily direct implementation. We do have a role in direct implementation of some programs, but we also have a role as as working with a subrecipient. Specifically, we have 2 subrecipients to CCA, which include HealthWorks, which is a subsidiary of the Kansas Hospital Association. They are working on 2 projects with us. And then KUMC, that there are 6 KUMC programs to which we are entering into a subrecipient agreement with the university and then having scopes of work for those particular projects. We'll talk about what those are in just a second. But as you can see, Kansas, we painted a broad stroke. We wanted to be as transformative and as innovative as possible. So we committed to doing a number of projects. We're beginning to see the comparison with other states, which really have viewed their RHTP program as a clearinghouse for grant funds to be awarded by RFP to rural providers. Instead, KDHE, KDAD, CCA, others are actually building infrastructure at a centralized point or on a regionalized level to support rural providers. Rather than saying, here's some money, go figure it out, we're trying to provide the support for the program as part of that. So where we are on implementation, we are in the throes of year one, which obviously is truncated because the awards were made in December, but you had to wait until you actually got the release of your funds from CMS by submitting your revised budget. Because remember, we applied for 200, but we got 222. So we had to recalibrate the budget to match that increased amount. We're in proof that it is lucky, better to be lucky than smart. When we recalibrated the budget, we made a decision to be as specific as possible. And so we named vendors, we named organizations specifically, we identified, principal investigators, submitted all of that application. What that meant, we didn't realize it at the time, but what that meant is that we had fulfilled many of the procurement challenges. We had met many of the procurement challenges that other states are now dealing with because we asked CMS, well, if you approve this budget and we said that this money is specifically going to the KUMC Wichita Department of Psychiatry to run this program, that means we don't have to go out to procurement for that program to send those monies out to the field. And they said, yep, you're right. And so we only have a handful of projects for which we have to take through the actual RFP procurement process. And so that has been part of our speed to implementation in Kansas. Again, just luck on our part. Although the first program year ends on October 30, we are required by CMS to be submitting our first annual report on August 30. And as in conjunction with submitting that report on August 30, we have to submit our request for the second budget period. And we have this much guidance so far from CMS on what that budget's going to look like. Whether we assume that we're going to get the same 222 million, do we go back to basing it off 200 million? Because the mix in here is that CMS has made very clear that if it is not satisfied with the state's progress in implementing its plan, it will reduce that state's award in subsequent years. So we're looking at Florida, we're looking at Wyoming, that they're just starting to spend money. We had approval of our budget on February 18th. We hit the ground running that day. The state has about 70% of its funds obligated at this point in time. Again, there are other states that have obligated a higher percentage just because they've issued more RFPs than the state. But we're feeling pretty comfortable about where we are. But we, of course, are not satisfied with that work and are continuing to see how much we can truly get accomplished by what effectively is the cutoff of July 31, but what will be in our annual report on August 30. Again, so not that we wish bad things upon Oklahoma or Montana or California or Alaska or any of those states that receive more monies than us. We are certainly going to pursue the opportunity to increase the funding for the state of Kansas because we certainly have creative and effective ways to spend it. Okay, before we get to specific programs, any questions generally about RHTP? I'm sorry, I'm not looking at chat. So if there's questions in the chat, let me know.
I haven't seen any questions just yet, but this is a lot of information. It's like a water hose coming at me right now.
we used to say that we were drinking from the fire hose, and now we say it's just directly from the hydrant. We have a lot of cute little sayings like that. Our favorite is Secretary Stanek reminds us that year one is just launch and learn. And we will certainly go back and we're figuring out where things were wrong. We've done some rebudgeting. It's a constant state of internal evaluation. So let's talk about the KUMC programs. So there were several KUMC departments that responded to the call back in September presenting opportunities. There are 6 programs that have been included specifically within the plan that will be led by KUMC departments. I'm just going to walk through these, give you kind of a flavor of what they are. There is in year one, 4.4 million is for what we call the Thrive program. It is led by the KUMC Wichita Department of Psychiatry, Professor Matt Byerly. It is an implementation of a computerized cognitive behavioral health therapy. If you can remember back to 2024, I think it was 2024, NIH had released an opportunity, about $25 million, on implementation research of supporting rural providers in adoption of evidence-based practice. There was a multi-departmental team that worked on developing that application, which was eventually submitted by the Department of Population Health. It was focused around Thrive. That was sort of the vehicle that would be used for implementation for that NIH research. Sadly, in January 2025, that program was pulled and never funded. So several states had applied, several universities, but it was never funded by NIH. It got doged, as we like to say. But that model remained. And so Dr. Byerly and his team had submitted a version of that as part of our HDP, and the state did fund that program and intends to implement it over the 5-year period. So work is beginning on that project. It's a very robust, it sounds simple, computerized cognitive behavioral health therapy, but it has a very robust implementation plan with deployment of community health workers, with multiple strategies at regional levels. And it includes within the program itself some implementation research to evaluate the effectiveness of the implementation model. Which of course, CMS does not consider that to be evaluation. So if that doesn't count towards our cap on administration. The KUMC Alzheimer's Disease Research Center submitted a proposal on their Lifestyle Empowerment for Alzheimer's Prevention, or the LEAP program. This program has been very successful in urban areas. This is the model to take that work out into the rural areas, and a significant interest. This is a program that gets such good response when we talk about this with rural communities because of such concern around brain health and really empowering those rural primary care physicians with tools both to help on prevention, but also diagnosis and then treatment. The University of Kansas Cancer Center, and if you've seen it, Hope on Wheels, its mobile van. It received funding to do mobile cancer screenings. It will average about 10 communities each year. The KUMC Institute for Community Engagement has 2 programs under Initiative 3, which is Workforce, the expansion of the Kansas Bridging Program, which is the dollars that are made available to residents that elect to practice in rural Kansas. It's expanding the size of the awards. It's expanding the scope of the awards to include specialists and also to include additional funds available for those that remain past their original commitment. Also an expansion of the HOSA program. HOSA is a high school program. I can't even remember what HOSA stands for. I apologize. It's just become a noun. But it's a program deployed in many Kansas high schools around exploration of health professions for high school kids. There are about 40 HOSA chapters now in rural areas. Our intention is to take that up to about 80. The program's been very effective in getting folks towards and into the career pathways for health sciences. And then the endocrinology, Dr. Tilden and his Data Doc project, he's been working on this for a number of years now with Children's Mercy, but it's a more effective use of data for individuals with diabetes, being able to gather that data, make it more readily available for the purposes of development of treatment plans. So those are our 6 specific projects with KUMC folks. We're still in the process of finalizing the subrecipient agreement with KUMC, defining the scopes of work. There's quite a process we have to go through with the state's fiscal agent that ensures compliance with all the federal procurement rules. And so I'm an old lawyer by training long ago, but I'm getting back my old skills of reading contracts and editing contracts and all of that stuff. But that's where we are. That's what it takes to get this done. That's what we'll do. Another program, kind of an indirect engagement by KUMC, is the Evidence-Based Practice Program. And this is our program for which CCA is directly responsible for implementation. It is intended to put dollars in the hands of rural hospitals and rural clinics very quickly, while providing dollars for infrastructure necessary to support evidence-based practice. Now, this slide is not completely familiar to all of you, I'm sure. It's why are there barriers to translating evidence-based practice into everyday practice? There's the old article that appeared in JAMA back in 2023, that it's 17 years from the research identifying best practice to actual implementation in physician practices in hospitals. How do we break down that 17-year barrier? That has certainly been the core work of the CARE Collaborative since its It started operations back in 2014. All of the work we do with the Care Collaborative is very hands-on. We don't ask them to come to a webinar. We don't ask them to come to drive to Wichita or Kansas City to go to a training session. We take the training to them. We do local boot camps where all the clinicians, the docs, the nurses, the administrative team, even the techs, everyone comes together and we work through evidence-based practice using best practices as identified by faculty at KUMC, but then working with the local provider to tailor that to the particular circumstances of that rural community. Because obviously what you do at an academic medical center and what you call best practices, there's going to be some translation. We have very different circumstances in a rural community, and that's what we work directly with these hospitals to do. That every one of those 70 rural hospitals we've worked with, we've done a boot camp directly addressing time critical diagnoses as well as diabetes. We've worked on heart failure, a number of other conditions. But these are the obstacles we're trying to figure out. And the concern here is we're trying to drive quality improvement by telling rural providers, here's a performance metric on which you need to report. Good luck, go figure it out. Not appreciating the investment of time and effort that takes within these organizations. Because trust me, every person working at a rural hospital has a hat tree that has a number of responsibilities that they have to put on any given day, and saying, hey, you need to make sure we're following best practices in responding to an MI in our ER. That's a lot of time and investment you're talking about, is working through the protocol, working it through medical staff, doing the training for medical staff, changing workflow, which certainly is probably the number one obstacle, is trying to implement a new program and addressing what we call the workflow potholes, and figuring out how you're going to fill those in. But that's a lot of time and effort for which we have not provided the resources for our rural providers. So that is the essence of this program, is let's give you the resources you need to implement evidence-based practices. So there again is our sort of core message statement for this particular program, is let's give you the dollars so that you can build infrastructure. Let's give you more technical assistance as best we can. Let's get you reporting on these performance measures so that you can identify opportunities for improvement in your implementation of best practices. And then let's take the scores you have on those measures, because I'm now going to have scores from multiple rural hospitals on a set of measures. I can now use that to demonstrate the quality of care that these hospitals are providing. Because as you know, many critical access hospitals do not participate in a number of the reporting programs. And so they don't have this data necessarily to present to their community, and importantly, to commercial payers to demonstrate the quality of the care they provide. And as we work through this, we know that we're helping these rural providers develop those capabilities internally that they'll need to succeed long-term under evidence-based payment models. So how's this program work? We're going to distribute $33 million in year one in the form of infrastructure payments and incentive payments. The infrastructure payments are 2/3 of the amount. An organization, a hospital, will receive $100,000. Clinics, which includes RHCs, FQHCs, CCBHCs, any clinic we can define, they receive $50,000 each. And here they commit to a work plan to implement evidence-based practice. They have an attestation form that they have to complete, having gone through certain steps, attended certain trainings, established certain workflows. And when they submit that completed attestation form to us, we then will make a payment to that hospital of $100,000, that clinic of $50,000. And we're doing our level best to try and streamline those requirements so we are not creating a whole new set of burdens on these hospitals, when what we're trying to do is provide them with the resources to move forward in a streamlined manner. The incentive payments, then, the other $11 million, are their reporting on specified performance measures. Now, that slide is so wrong. I am so embarrassed. They are actually reporting for July, August, and September. They will report those in October. And we're using, if you're familiar with the QHI system that's sponsored by the Kansas Hospital Association, so we're using a common reporting platform for these hospitals. Once they've submitted their data, this is pay for reporting only this year, $50,000 for the hospitals, $25,000 for the clinics. These are the hospital performance measures. No surprise, right? As we have always been, focused on those time critical diagnoses, but also we have learned, and the evidence is telling us, that when a rural hospital focuses on discharge checklists, specifically around patients with diabetes, patients with heart failure, and have our discharge planners working directly with the patients and their family members on those checklists, sending information to the local pharmacy. We know we're getting better outcomes. So a focus on those checklists. And then because we're dealing with some smaller hospitals that may not necessarily have patients in those measures, because we're doing 3 months, it's not uncommon. We've got smaller hospitals out there that will not see a stroke within the 3-month period. So we have two alternative measures, which is ED arrival to QMP contact and this discharge med reconciliation list. Good news is most hospitals are doing all seven. And they're going to select then which of the 5 they'll actually report on. We again streamline as much as we can. 15, you randomly select 15 cases, report on those for a 3-month period. Is that your opportunity? For clinics, we have 8 measures, and here's where we really have pulled on our colleagues at KUMC to support a number of these initiatives. BMI is sort of, again, what someone told me, the BMI is a great measure for a population, a terrible measure for a person. And so the alternative is the abnormal waist to height ratio. And so we are moving rural providers to using that as an evaluation tool for preventative services, then documenting an action plan and referring individuals to community service. So a much more aggressive way of dealing with obesity and other diabetes prevention. Lung cancer screening, we have called on our colleagues to help develop out materials for rural providers to perform lung cancer screenings, which again is a much more involved process, and helping them learn the different steps and then the treatment available for them. Starting prenatal care and trimester, postnatal depression screening, very primary care focused issues, trying to address a lot of our maternity desert issues, intervening early. One area in which the Care Collaborative has worked has been mobile simulation training for OB. Incredible response to that program. Got some funding from HRSA, purchased, a van and a bunch of mannequins, and worked closely with KUMC that run those simulations. And the response has been overwhelming from the hospitals that want that basic OB training for those that do not actually deliver, as well as those that do. And then dementia screening and Alzheimer blood biomarker session, again, partnership with KUMC and the Alzheimer's Research Institute, doing some really in-depth webinars, and again, the workflows and the like to support the clinics in these areas. So one of our challenges with this program, obviously, is because you can't double dip with our HTP funds, we had to find measures that are not part of other core reporting programs. And so that's really given us an opportunity to kind of think out of the box and really push as best we can through these measures, evidence-based practice in these key critical areas. Let's check our time. Oh, God, we're doing great. Got 5 whole minutes. Very briefly, introduce the Anchor Hospital Advancement Program. This is focusing on those hospitals in rural Kansas that kind of serve as specialist hubs. And can we support those hospitals so that they can do a better job supporting their surrounding hospitals? And so there were 10 hospitals that were selected to be part of this program. You see the eligibility criteria we utilized. You see there the 10 hospitals that met this criteria. The CEOs of these hospitals have formed a board. They meet once a month. They are doing a lot of planning and work around their different areas of assignment. One of the areas, these are their 4 initial year 1 focus areas. Number 4 is the KUMC residency program. Dr. Latham has been working very closely with the AHAP program on expanding rural residency programs or rural opportunities within residency programs. For year 1, there's $2.2 million that's focused in on standing up the infrastructure to support these expansions of rural residency programs, those that exist today, but also importantly, building relationships with these anchors so that they can continue to expand out those programs. So for example, Hutchinson has been working with the Department of Psychiatry to build an expanded psychiatry program, or who's working with orthopedic Salina. I kind of get all the names mixed up, but again, these are kind of long-term plans, 5-year funding to get these programs established as well as best they can. There's also funding separately going to the Kansas College of Osteopathic Medicine to support a family residency program they're establishing with small hospitals out in western Kansas. The AFEM program, or Accountable Food as Medicine, certainly an area of emphasis, but also a vehicle really to continue supporting community health workers out in rural areas. The deployment of staff both through KDHE, they're working with the rural primary clinics, but also K-State, putting CHWs in the regional extension offices, then supporting practice facilitators, nutritionists, and because we need food, agricultural specialists, some really cool stuff going on, talking with farmers about converting a portion of their acreage over to growing local produced foods to support these food as medicine programs. Trying to have a very broad charge to our community health workers, not just focus on the food as medicine intervention, but also sort of be a key to a number of these other interventions. So think about LEAP, for example. How are we going to get the LEAP program out in the hands of rural residents? Part of that's through primary care, but also through these CHWs that can help the individuals with whom they're working identify that need and get them to that product. Engagement here by the KU Department of Family Medicine and Community Health Engagement. They are working on CHW training and also have a role in there is program evaluation here. Again, it's implementation research, but really to understand how can we finally get to the point of sustainability with community health workers. That is our number one priority with this program, is figuring out the sustainability model over the next 5 years. That's it. I have made it through all of my content for today. I am happy. There's obviously a lot more to the RHTP program, as you saw. Oops, I'm not doing this right. I gotta figure out how to stop sharing. There it is. That work? There we go. There we go. And again, happy at any time to answer questions. If you see opportunities for partnership, appreciate we're getting into year 2, like, tomorrow in terms of doing the budget. We're stuck with, we have the programs we have. Certainly we want to continue to evolve this program. And so if you see opportunities with the work you're doing, please reach out, because we do want this to be, we're not going to continue to throw good money after bad. And so as we modify these programs, we have more opportunities. So there, I'll stop and see what questions we've got.
Thank you, Marty. I'm going to watch the video back for sure, to just do more line by line analyzing. So thank you for this presentation. I think people are hungry for this knowledge. And just like Kevin did, if you can just hit the raise button if you would like to speak, so we can make sure I call people in order. The first question that I'm just going to jump off and ask, has there been any funding dedicated to informing the public about this plan?
Not enough. Absolutely. We're friends, right? We're all friends here.
Yes.
KDHE is a really interesting partner to work with, and they're great. I mean, Secretary Stanek has been amazing. I mean, she is just the most practical, get it done person. And she has a hospital background. She was the COO. And Matt Lara just digs in and gets the work done. And they've got a good team of consultants, but it is very hard to convince them that they need to be doing more public outreach. We are doing our best. We are talking, and I think we're going to do this now, is sort of do a state of the state from our perspective, from the role we played as the partner to KDHE and where this program is. There's still a lot of misperception. I mean, I still get the calls from the hospital saying, why aren't you just sending us a check? Because if I send you a check, you're just going to spend it and we're going to be no better than we were before. We've got to figure out how to transform the system and make it work. And we're going to try it from a lot of different angles, and some of it's going to work and some of it's not. And it's our job. We need the feedback from the community, right? Because they're the ones living it. We're not. I live in Kansas City, got to admit it. But we need that feedback from communities, and we're only going to do that if we're doing better outreach. So, CCA, we have a contract with the state. The state pays us a monthly fee, and that buys me, Dr. Mosier, Jody, Nicole Palmer, a host of other folks that are working on this. Our team is about 12 people in the CARE Collaborative, doing lots of other projects, right? We've got a $12 million Patterson Family Foundation grant for the virtual campus that we have to continue to support, right? And we've got other HRSA grants we've got to continue to support. And we've got a clinically integrated network that we're trying to figure out how to negotiate with Blue Cross Blue Shield of Kansas we're trying to promote. So our staff does have funding available to us, but it's just a matter of right now, it's a lot of launch and learn, building it while you're flying it, yada, yada, yada. We've got to do more outreach. And the more you can tell me I need to do that, the more it reminds me I need to do that. So that's great to hear.
I think you're doing fantastic work with the constraints that you have. Kudos, my hat goes off. And I'll pass it on to Kevin, and then followed by Alan.
Yeah, this is my retirement gig. This thing's over in 5 years and I qualify for Medicare and I'm out of here. Trust me, this is it. So it's fun to come to work every single day and do this type of stuff, and I love talking to people about it.
Hi there, I'm Kevin Elliott. I'm on the State Medicaid Advisory Board, the member committee. And we talk about this all the time. We're so excited. This is great for Kansas. I have a couple questions, but I'll try to keep them as brief as possible. One is a concern question, and that is because these funds were originally added to because of the concerns of closures for hospital, but these funds aren't going to help hospitals to keep from closing. How is this grant going to react when hospitals start closing? Because there are a number of hospitals that are in danger of closing. And the second question, as a Medicaid advisory member, the biggest questions we get from rural communities are access to transportation, which there are funds for, but the infrastructure doesn't exist. And tied to that same question is home health aides. There are funds for, but the infrastructure doesn't exist, and the pay level doesn't exist in the state of Kansas. And
Right.
and that's a lot, but I'll leave it at that.
Yeah, I mean, when the Chartist does this annual report on hospitals at risk of closure, and yeah, guess what? 82% of Kansas rural hospitals operate in the red. It is because Kansans really want their health care and support it with local tax dollars that we don't have hospitals closed in Kansas. If you look historically, Kansas only has like one or two hospitals that closed because of financial issues. I mean, we lost Fort Scott, we lost Independence because Mercy walked out on them, right? We've lost hospitals that have converted to REH, so we did avoid some issues there. It will be interesting to see what happens when hospitals close, because there is a contingency out there that think we have too many hospitals and some should close. And so I think that's going to be part of the story. And really, our evaluative tool should not be how many hospitals there are, it's how good access to care is. So I should mention this. One thing we have within the program is the Docking Institute partnering with KHI to do public perception in rural communities of access and quality to healthcare. And so they've just put their first survey out in the field. They'll do that 2 more times. And that's what we're really focused on. What's the public perception of access, both primary care, specialty care, behavioral health care? And I think that'll be interesting to see where that conversation goes, right? Are we here to prevent hospitals from closing? No, that's not our number one concern. Our number one concern is, do people have access to the care they need? So there's that. Transportation, absolutely. There is a whole program. It's interesting. We put transportation under Initiative 4, which is value-based care, because you can't have value-based care if you don't have an effective and efficient continuum of care, right? You got to get right head, right bed. That ain't going to happen if you don't have a transportation system that can take a patient from a small rural hospital that needs a tertiary or quaternary level of care. You got to get them there, and you got to do that efficiently. And the horror stories of how many times a patient is transferred 2, 3, 4 times in the course of a condition because it has not been coordinated well. So we've got both a communication issue and a physical transportation issue, and trying to address both those with programs that include, over the next 5 years, we're going to create a system of transportation hubs that are merely focused on interfacility transport, right? They're not going to be responding to emergency calls. They're going to be moving patient from community A to community B and back home again. So we'll be building up those hubs throughout the state. We're very focused on behavioral health transports because that is one of the significant stressors for rural hospitals. They get patients that are parked in their ERs because they can't get them to the appropriate level of psychiatric treatment. And it's creating a network using available resources that exist in Kansas, just putting the money where it needs to be to reinforce that we can get those patients referred and transported more effectively. So it's part of the story, right? And I mean, there's a lot of holes in EMS out there. I'm not sure we ever could have enough money to glue it together, but it's something where we're at least trying to systematically address some of those issues. And back to Medicaid. I mean, Medicaid is definitely a hit on part of the sustainability plan. We've got to make some changes in what's covered by Medicaid. We've got to make some changes in CO behavior. Because they have all these obligations toward care coordination, which of course includes transportation, but they've been very less than embracing of those particular issues. So a lot of words, but Kevin, please don't hesitate to reach out if there's anything more specifically we could delve into. Melinda, I want you to know I have the same picture on my wall.
Alan, please go ahead.
Well, we are almost out of time. I just wanted to thank you so much, Marty, for coming and talking to this group. I don't know how much you know about our MARG group. We're a group that's been around for a while now. And I think I would just say, most of all, if you, in all this great work you're doing and the network of networks that you're creating with this, if there are people who want to know how to get community voice and get community input into things, this is the group, because more than half of this group are community people and community advocates who input to health people, whether they're researchers or health doers. So we would love to help with that if that issue is ever coming up. I think that's a big one. And then you also mentioned, which I don't blame you at all for wanting to ride off into the sunset, but I think there's a lot of us who want to know, what's the succession plan as this unfolds, because I think we're not bringing the youth, the young providers, the young leaders, people in healthcare, public health to the table and mentoring the next generation, because we all know this is going to be over and there are going to be huge Medicaid cuts. So I'm curious to know if there's anything going on with that. And we don't even have time to talk about it, but I think we need to work on that as this unfolds too.
Yeah. Thank you, Dr. Gribe, for this is a group we will reach back out to, because again, we always say, 50 days, it's a bad excuse. We did not have the level of true consumer engagement that we needed in the development of this. It should have been a year of planning. And again, I just have to get over that at this point. But we have programs that are going to need that input. And accountable food as medicine is probably one of the greatest examples of that. So now that I know who you are and where you are, I will find you again. Thank you very much. And you're right. There are some, it's great. For part as I am seeing the young people out there, kind of the young policy nerds like myself. And this is a great opportunity for them to get their hands really dirty. And they're starting to learn how this Kansas infrastructure works. I apologize. I've got to jump to a 10 o'clock meeting, but thank you so much for this opportunity. Again, do not hesitate to reach out. I have a KUMC email address. And happy to answer any questions, have conversations about this, because we are all learning as we go. Trust me. Okay?
Yes. Thank you again, Marty. We appreciate you.
Thank you. Bye-bye.
Goodbye, everyone.
Email
Wonderful.
address.
Oh, I'm sorry. Go ahead, Lisa.
I was just asking, can you put her email address if you know it in the chat for us? Thank you.
Absolutely. Have a wonderful summer, everyone. And every